Okay, moving on to bone tumors. The first tumor is an osteoma. Osteo means bone and oma means mass. So this is a benign tumor of bone. Now there are two high yields for an osteoma. Number one, it most commonly arises on the surface of facial bones. And number two, it's associated with Gardner syndrome. Now recall from our GI lecture that Gardner syndrome is familial adenomatous polyposis plus fibromatosis in the retroperitoneum. And again, fibromatosis is a non-neoplastic proliferation of fibroblasts that grows and locally destroys tissue. And then number three, osteomas of the facial bone. And so here we're talking about those osteomas that are associated with Gardner syndrome. So that's particularly high yield for board examinations. Osteoid osteoma is a benign tumor of osteoblasts. Remember that osteoblasts are the cells that lay down bone, but they don't make bone, they make something called osteoid. Osteoid is the matrix that gets mineralized, and when it gets mineralized with calcium and phosphate, then it becomes bone. And so this tumor produces osteoid, and in response to this osteoid, so imagine this is the osteoid here, you get a rim of sclerotic sort of reactive bone, and that's what's called the osteoma. So basically here is the osteoid, and here this rim is the osteoma. So let's read this now. So this is a benign tumor of osteoblasts, which make osteoid, surrounded by a rim of reactive bone, hence the term osteoma. It occurs in the cortex of young adults, less than 25 years of age is sort of the classic demographic, and it arises in the cortex of long bones. Now let's go back and remind ourselves that the bone has a cortex, which is its surface, and then there's a medulla. And so this tumor is going to arise on the cortex of the bone. And also important to note is that it usually arises on the diaphysis in a long bone. So for example, if this is the growth plate, then above the growth plate is called the epiphysis, the growth plate region is called the metaphysis, and this long shaft here is called the diaphysis. And so osteoid osteoma usually occurs on the cortex of a long bone in the region of the diaphysis. Now the presentation is also important, and that is that the patients have bone pain, but it resolves with aspirin. And examiners really like you to know that in an osteoid osteoma, the bone pain resolves with aspirin. Now when imaging is performed, you'll see a bony mass with a radiolucent core. Again, the idea here is that you've got a center core of osteoid, which will be radiolucent. It won't get picked up on the x-ray. However, that will be surrounded by a rim of reactive bone, which will light up as white on the x-ray, i.e. the color of bone. And so that's what we mean here when we say that you get a bony mass with a radiolucent core. The bony mass represents the rim, and the center, the core, represents the osteoid. Now osteoblastoma is a benign tumor of osteoblast. It's very similar to osteoid osteoma because that was also a benign tumor of osteoblast. However, there are three key differences that are very high yield. Osteoblastoma is larger. An osteoid osteoma is usually less than 2 centimeters, and osteoblastoma is usually greater than 2 centimeters. The osteoblastoma usually arises in the vertebra. Remember that the osteoid osteoma arose on the cortex of the diaphysis of long bones. And number three, an osteoblastoma presents as bone pain that does not respond to aspirin, very high yield. Whereas with an osteoid osteoma, the bone pain would respond to aspirin. Osteochondroma is a benign tumor of bone with an overlying cartilage cap. It's the most common benign tumor of bone, and it arises from a lateral projection of the growth plate. Now let's illustrate this. Here is the bone. This is the growth plate. And recall that the growth plate is made of cartilage. Now as the growth plate expands, it will then result in the elongation of the bone producing linear growth. Now imagine if you had a lateral projection of the growth plate like this, then that would then subsequently result in, for example, a projection of bone with a surface of cartilage on it that would look like this, because this here would actually also grow, but it would grow this way. And so this then results in the tumor osteochondroma. So again, if this was the tumor here, the bone here represents the osteo, and this cartilage cap that came from that lateral projection of the growth plate represents the chondro, and the oma represents the mass, so osteochondroma. Here's a picture of an osteochondroma. This entire thing represents the osteochondroma. imagine that it would be coming off the surface of bone here. So again, what would have happened is you had a lateral projection of the growth plate. The lateral projection of the growth plate will then grow, and when it grows, you'll get a surface of cartilage. Notice this white here represents the cartilage, underlying which would be bone, and this represents bone. And one of the important things is that this will normally be contiguous with the marrow space of the bone from which it's growing. So if this was the bone from which it's growing, it'll attach and be contiguous with the marrow space. And that's also very important concerning an osteochondroma. Now the final point is that overlying cartilage on the top of the osteochondroma can transform into a malignant cartilage tumor, and that would be called a chondrosarcoma, and that's particularly important as well. Osteosarcoma is a malignant tumor of bone. Osteo means bone, and sarcoma means malignant mesenchymal tumor. And of course, it's the osteoblasts that make bone, and so the proliferation is actually of the osteoblasts. Now the peak incidence is seen in teenagers, but less commonly it can also be seen in the elderly. Here's a graph of the peak incidence. So here is the teenagers, and here are the elderly. Of course, this would be the incidence. Now, it's important to note that some of the risk factors that lead to osteosarcoma include familial retinoblastoma. Familial retinoblastoma, recall from our neoplasia lectures, leads to an increased risk for bilateral retinoblastoma and osteosarcoma, particularly high yield. And that would be something that would lead to risk within teenagers. In addition, we have a peak here with the elderly, and there are two very high yield risk factors to be aware of. Number one is Paget's disease of bone. Recall that when we talked about Paget's disease of bone, I told you that it normally occurs at the age of 60, and I also told you that one of the complications was osteosarcoma. And do you remember the second complication? The second complication was high output cardiac failure. But anyway, Paget's disease of bone has an increased risk for osteosarcoma. And the second important thing that leads to an increased risk in the elderly would be radiation. So radiation exposure would increase the risk within the elderly. Osteosarcoma classically arises in the metaphysis of long bones. Again, here's a picture of bone. You've got a growth plate here. And so what's above the growth plate is called the epiphysis. The region of the growth plate is called the metaphysis. And this long shaft here is called the diaphysis. So osteosarcoma normally occurs in the metaphysis, and that's particularly high yield for board exams. Now, it'll usually occur in a long bone, classically the distal femur or the proximal tibia, so around the region of the knee. It can present as pathologic fracture, which basically means that the tumor weakens the bone, which then makes the bone susceptible to fracture, i.e. the fracture occurs because there's some sort of pathology underlying in the bone. Or it can present with bone pain with swelling. In either case, an X-ray would be performed, and this is the classic finding that would be seen on X-ray. Here you can see that there's a destructive lesion growing within the bone. This represents osteosarcoma, and one of the high-yield things that examiners like you to know is that osteosarcoma, as it begins to grow and expand the bone and eventually go into the adjacent soft tissue, one of the things that it will do is that it will drag the periosteum, which is a layer of connective tissue attached to the bone, off the bone. So imagine here, if this is the surface of bone and it's covered with periosteum, you can clearly see that here the periosteum is being lifted off the bone. Now that creates an angle right here called Codman's angle. And board examiners like you to know that Codman's angle is a sign of osteosarcoma. In addition, with osteosarcoma, sometimes you can see this hazy radio opacity coming from the tumor, which almost looks like the burst of sunlight coming off the horizon. It's not very well illustrated in this image. It basically represents the tiny fragments of bone being produced by the osteosarcoma. If a biopsy was performed, the key finding would be large pleomorphic cells, i.e. high-grade malignant cells, that are producing this pink matrix called osteoid. Again, pleomorphic cells that are producing osteoid is the hallmark on biopsy. Giant cell tumor is a tumor comprised of multinucleated giant cells and stromal cells. It occurs in young adults. One of the very high yield points is that it arises in the epiphysis. Now, of course, this is the diaphysis, and here's the metaphysis, and up here is the epiphysis. Now, this is very important because it's the only tumor that you need to know that's going to arise in the epiphysis. And so on board exam, if you have an epiphyseal tumor, that's basically giant cell of bone. It usually arises in the distal femur or the proximal tibia around the knee, and it's kind of similar in location to osteosarcoma, actually. Now on X-ray, you'll see something called the soap bubble appearance. And the idea here is this is the diaphysis, and then this is the metaphysis, and up here is the epiphysis. You get the tumor growing, and in response to the tumor, you get a little bit of reactive bone formation circling the tumor, and a bunch of these little areas of bone reacting against the tumor form, and so it produces these bubbles that look like soap bubbles in the epiphysis. So soap bubbles in the epiphysis is giant cell tumor of bone. This is a locally aggressive tumor that may recur. Ewing sarcoma is a malignant proliferation of poorly differentiated cells derived from neuroectoderm. Board examiners like you to know that Ewing sarcoma is derived from neuroectoderm. It arises in the diaphysis of long bones, usually in male children, so basically it would be here, and it grows inside the medullary cavity. Now as it grows inside the medullary cavity, it is then going to push on the surface of the bone, and as it pushes on the surface of the bone, you're going to get layering of new bone by the periosteum. Remember that the periosteum is a connective tissue that surrounds the bone, and it also has the ability to produce new bone. In fact, when you get a fracture, for example, it's the periosteum that forms a new bone. And so as you put pressure on the surface of this bone with the tumor growing in it, the periosteum will begin to lay down layers of new bone. Now those layers of new bone will have an onion skin appearance on X-ray. Imagine if you looked at the bone head on, you would see sort of an onion skin layer, another layer, as the periosteum is being laid down, trying to protect the bone from this tumor that's growing inside. If a biopsy is performed, it'll show small round blue cells. All of these blue cells here represent the tumor, and these cells resemble lymphocytes. And that's very important because it can be confused with two things. Number one, it can be confused with lymphoma, and number two, it can be confused with chronic osteomyelitis. Now, one of the interesting things about Ewing sarcoma is that some patients can present with fever. Now imagine if you have a patient that has swelling of the bone and has fever, one of the things that you're going to think about is osteomyelitis. So it can be confused with number one, lymphoma, or number two, osteomyelitis. However, what's going to clearly distinguish these cells from both lymphoma and osteomyelitis is the fact that these cells have an 1122 translocation. And that 1122 translocation is particularly high yield for Ewing sarcoma. Ewing sarcoma is fairly aggressive and it often presents with metastasis, but it also responds well to chemotherapy. Moving on to cartilage tumors, let me just highlight a couple simple principles that'll make this discussion very easy. Number one, cartilage tumors can be benign or malignant. Benign cartilage tumor, chondroma. A malignant cartilage tumor is called a chondrosarcoma. Number two, cartilage tumors arise in the medulla. So remember that when you have bone, you have a cortex and you have a medulla. Cartilage tumors normally arise in the medulla. Number three, benign tumors, i.e. chondroma, they occur in the small bones of the hands and the feet. And malignant tumors, i.e. chondrosarcoma, occur centrally in the pelvis or the central skeleton. And those are the key take-homes. Now let's read together. So chondroma is a benign tumor of cartilage. It arises in the medulla. Cartilage tumors normally arise in the medulla. And because it's benign, it'll be in the small bones in the hands and the feet. Here's a picture of the tubular or small bones of the hand, and you can clearly see that there's this mass growing in the medullary space, and again, this represents a chondroma. Chondrosarcoma is a malignant cartilage-forming tumor. Again, because it's a cartilage tumor, it usually arises in the medulla, but in this particular case, it'll be in the medulla of the pelvis or the central skeleton. And so these are some of the basic high yields concerning cartilage-forming tumors. The final discussion involves metastatic tumors. Metastatic tumors are more common than primary tumors in the bone. They usually result in osteolytic lesions or punched out lesions of the bone. However, one important high yield exception is prostate cancer. This usually produces an osteoblastic lesion. And so what that means is that when you look at the bone, instead of having this punched out circular space as would occur in osteolytic lesions, in an osteoblastic lesion, you get activation of the osteoblasts and they begin to lay down bone adjacent to the tumor, and that gives you sclerosis of the bone. And so again, prostate carcinoma classically produces osteoblastic lesions. And that concludes our discussion of bone tumors.